topic that we're discussing today. As we continue forward through DSAM's various prevention initiatives and participating with and alongside other agencies and organizations' prevention initiatives, we want to bring approaches around trauma-informed prevention and equity to the forefront. And this learning opportunity will help us all elevate the importance of these focus areas in our work. We look forward to your participation in today's discussion, and thank you again for being here. And I'll pass it back to Carlton.
Abby, thank you so very, very much. Again, partnering with you and Dana Carr, as well as Elizabeth Romero, who really provides the leadership for these efforts and these initiatives, as well as our good friends in the Children's Department. We thank you at the state of Delaware for thinking that this was important enough for us to be able to provide this opportunity for your grantees. With that, I really want to make sure that we pay attention to the fact that this is not happening without the great support of the Substance Abuse and Mental Health Services Administration, or SAMHSA, and funding that's being provided through that. I will share with everyone that this webinar is being recorded and archived and will be available for viewing after the webinar takes place. Contact us with respect to any challenges or questions that you have with respect to that. I will talk to you about how you will be able to access this recording toward the end of this presentation. Please note that the views expressed in this webinar do not necessarily represent the views, policies, and positions of the Substance Abuse and Mental Health Services Administration. And so we thank them for their money, but we get them off the hook for anything that we would happen to share with you. Dave shared with you that we are doing this through this platform. I will just ask him to very, very briefly and quickly share with you some of the functions that might be of service for us.
Yes, thank you, Carlton. Starting in the bottom left, you'll see the unmute button. So that's where it will show when you're muted, and you'll have the option to unmute later on if we have some questions. Next to that is your video. We love seeing your smiling faces, but we do understand some folks might not be comfortable having their cameras on. We understand. Then moving along to the right, there's the participants section. You can click that, and then that will open up the box on the right-hand side that shows everybody's name. And while we're talking about the participant list, at the bottom of that, there's the option to raise your hand or put a cue in to say, slow down, go faster. Feel free to use those. Part of my role here as a producer will be to monitor the chat box and watch for those reactions, both through cameras and in the participant list. And then also moving along, there we go. Moving along to the right, you can see the chat box button there. That's what will open the chat box. Feel free to utilize that throughout with any questions, comments, or any technical difficulties. And if you want to give a little round of applause or a thumbs up throughout, that reactions button is how you can do that. And some folks, your view might be a little bit different. So if you look at the top right of the shared screen, it says speaker view. You'll have gallery view or a speaker view there. That's how you can change the layout. So you can see multiple webcams all at once, or just one single webcam for the active speaker. And that's all I've got for right now. But again, feel free to use that chat box. That's what I'm here for. Thank you very much.
Thanks, Dave. As we mentioned, we are grateful for the opportunity to partner with the folks at DSAM and the state, as they've made it a priority to build the capacity of their prevention workforce. And so it is our great honor to have that opportunity to be offering a series of conversations that we will be discussing later on toward the end of this webinar. I want to start off simply by sharing with you, as you're looking at the screen and looking at this activity, anyone that has worked with me knows that I like to start off with a bit of fun, but with some relevance. And so to take advantage of what Dave offered, to show that you are engaged in this process, I would like for you to put in the chat box the number of holes that you see in this shirt. If this was an actual shirt, how many holes do you see? Go ahead and put those in the chat box. I'm only providing 20 seconds for you. I'm only providing 20 seconds. Go. Dave, share with me what they may be putting.
A lot of sixes, got a 4, an 8, 6, 6, 6, 5, 6.
Okay,
Keep them coming. Looking good.
I'm going to cut it off here. So you guys, I don't know if we're all looking at the same shirt or not, but if this were an actual shirt, if you see this hole, there will be 2 holes there. There's one in the front and one in the back, that's 2. There's another 2, one in the back, one in the front, that's 4. There's a hole here for your head, that's 5, right? There's another one at the bottom, that's 6, and then you have 2 more for your arms to go through. So that's a total of 8 holes. And I share that only to say there is an old adage in our communities that suggests that you can't really solve a problem if you can't really see that problem. And that's really what today's session is really all about. Whether you are a grantee with respect to working with children of victims services, or you're developing coalitions throughout the state through the Drug-Free Community Support Program, or you are responsible for implementing science-based prevention efforts through your communities, through the Partnership for Success opportunities that are being offered through the state. The state in the last year has made a priority of looking at things through a developmental framework for trauma-informed care. And the governor and everyone throughout the administration is responsible in encouraging this support. And so I would be remiss not to mention the phenomenal work that is being done throughout the state, much of it being led by Ms. Terry Lauer. Ms. Terry Lauer and her work at the Department of Education has been responsible for really leading this effort on behalf of the state. I had a remarkable communication and conversation with her. I was hopeful to have her voice on this particular webinar. I know that she will be listening in and participating in some way, so she is there, but she is an extraordinary champion on behalf of this work and this effort. Our hope and our attempt is to be an additive to the great work that is being done in the state and the work that's being informed by Ms. Terry Lauer and her team. So with that said, it is my extraordinary privilege to introduce, this slide is really a bit of a misnomer. I am simply setting things up. I am not presenting today, but you are all going to receive the wonderful presentation and suggestion from my great friend and extraordinary champion in her own right. Dr. Cerise Hunt is the director for the Center for Public Health Practice at the Colorado School of Public Health at the University of Colorado. In this role, she is responsible for the formation of community linkages that guide public health practice, provision of continuing education and workforce development opportunities in public health, and engagement in public health practice research. She was instrumental in the formation of the Colorado Black Health Collaborative and Far Northeast Health Alliance. She has served in numerous capacities. She is a remarkable champion. She's one of those unique individuals whose passion for this work, as well as her great and serious contribution to our field, makes her one of the leading thinkers in our nation. We are extraordinarily blessed to have her as part of the CHC team. And with that, Dr. Hunt, I am turning it over to you. So please share with us your presentation. And you have to unmute yourself.
Well, good day, everyone. Thank you, Carlton. Carlton, I got to take you with me on all my talks. You make me look really good. But some things that some of you may not know about me is my career started as a caseworker at Denver Department of Human Services. So I worked in the family and children's, specifically in substance abuse prevention for a family preservation program for mothers. And so that is my background. So this topic is near and dear to me. So I'm just very excited to be here. And before I begin, I always like to challenge participants, because there's always a challenge. as I go through my presentation, as we get, because this is a learning community, we're constructing this together, we're learning together. I want each of you to begin thinking of specific things you can do to advance equity. All these practices, all these different, procedures that I'm going to talk about are probably familiar to you. But what often happens is we forget about, well, how does this apply to my day-to-day practice? And so in order to advance any type of equity work, we have to be intentional. And that intentionality begins with us. And so if we're going to talk about, we hear a lot folks talking about, dismantling systemic structures and make sure all these different things. Well, we have to remember, we are the folks that build up the system. We want to point to people at the system, but I like to say we make the system. So I just want to start off with that as we go through the talk today. We're going to, just kind of let you know where we're going. We're going to assess and look at, by the end of this talk, you'll be able to assess and engage the community and specific target populations using culturally appropriate communication methods. We're going to talk about, well, how do we engage community? What is the best practice? And we're really going to identify ways to identify and implement trauma-informed prevention strategies that meet the needs of hard to reach target populations. And so really thinking outside our comfort zone. We have a tendency to work with communities that are our favorite, that are easiest, but what about those hard to reach populations? Are we delivering our services that are culturally inclusive and culturally responsive? And I always like to start with, kind of operationalized terms. And what we're inspiring to do is really to becoming a trauma-informed practice. And I'm just going to go ahead and read through this because it's very important. A program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery. So we know that there's more than one path. Recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds. This is what's key, because when we're talking about becoming, you're going to do something. But what's key is that you respond by fully integrating knowledge about trauma, and this is the kicker, into policies, procedures, and practices, and seeks to actively resist re-traumatization. So this is what when we're talking about becoming and what we're working towards, it's the way we all do business, not certain folks, but individually. It's that expectation that we create. And so before we start talking about equities, equity and doing things, I want us to really begin by thinking about health disparities. And I know this source is from Healthy People 2020, and I'm pretty sure I haven't seen a release for Healthy People 2030. I can only imagine with the recent COVID-19 response to health and what we're seeing in the disparities, they're probably still working on this. But I want you to know that it's a type of difference in health that is closely linked with social or economic disadvantage. And what's kicker is that it negatively affects groups of people who have systematically experienced greater social or economic obstacles to health. And these obstacles stem from characteristics that has historically linked to discrimination or exclusion. And I want to really emphasize the historical aspect. When we look at the health and the wellness, specifically with some of our racial and ethnic groups, there's a historical component of not being included, of discrimination that still permeates our systems now. And so when we're talking about structural racism is embedded in the inequities that are built up within our systems. And that's the historical link. And so this is around race, ethnicity, religion, socioeconomic status, gender, sexual orientation or sexual identity, geographic location, and behavior health, one's mental ability and capability. So this is the disparities. And specifically, behavioral health disparities refer to differences in outcomes and access to services related to mental health and substance misuse, which are experienced by groups based on their social, racial, ethnic, and economic status. So to get us thinking, so now we know that there's disparities, I want us to do a quick poll. This is just a way for us to engage. And so the question for our poll is, will free access to health and wellness care services eliminate health disparities? We know that there's a historical component. Is free access to everyone, will that eliminate? If you could please respond, and we'll give you a moment to respond to the poll. And you'll just pick yes or no, unsure, and just hit the submit button.
The polling window should have just popped up on your screen to give you that option, yes, no, or unsure. Are you able to see that? Can I get some head nods, shakes, no?
I can see
Looking at it, all right. Good.
Dave, I'm not seeing the poll.
Not seeing it? Okay, let me relaunch it. Okay, relaunch the poll. Okay, how about now? It's relaunched. Are you able to see it?
I can see it on my end.
Abby?
I'm not able to see it, no.
A couple folks do see it. Okay.
I wonder if it's being a co-host versus a
That's what it is.
presenter
The
or
participants
something.
are writing that they're seeing it. So do you have responses?
Okay. Good, good.
Sorry.
It's not showing any responses coming in on my end. Folks are seeing it, but it's not registering responses. So that might be a Zoom glitch we're experiencing.
Okay, so one of folks put it in the chat.
Yeah.
If you can put
Technology
it in the
is
chat.
great, isn't it?
Yeah.
Okay,
No,
so you
I'm
got.
seeing some no's. I say no. Okay.
Yep.
Okay, so the majority that came up was no. So it did come up on my end. Okay, I want to thank everyone. And like I said, I see the majority of no's to that response. And so, like I said, and you're right, because what we know when it comes to healthcare and service and wellness services is that there's different types of disparities, okay? It's not just your health status, how you feel today, pain, discomfort. And when we look at health and wellness, typically folks just look and say, well, we just look at one status. But what our research has shown us is that types of disparities are rooted in inequities. So it's not just access, it's the quality of care. And so, and specifically for communities of color, and when I'm talking about communities of color, I'm talking about the Black, African-American population, our Latino, Hispanic population, our Asian Pacific Islander population, and our First Nations, our Native American and Indigenous populations, and Alaska Natives, that they do not receive the same quality of care. And the quality of care is due to bias of provider, having accessibility, accommodations, affordability. So even if we have access to care and everyone has access, and it is free fare, but sometimes with specialty services, there's not enough for everyone. So there's multiple barriers that contribute to the inequities that folks experience. So when we're thinking about one's health, and I love this slide because it really breaks down health to, we know genes, and clinical care, that makes up about 20% of health, and health behaviors. So we're looking at about 50%, but the other aspects of health really looks into the social and economic factors. That makes up 40% of one's health, in addition to the physical environment. And so these tie in and make up one's health. So it's not just enough that we're saying that individual needs to take care of themselves. We know that there's social and economic factors and one's physical environment, in addition to clinical care, because clinical care is up to the providers that impacts one's health. And so it goes beyond just genes and health behaviors. And so when we think about these barriers, there's multiple factors that contribute to the disparities. Individual, I just talked about provider, health systems, how our health and our wellness, all of our, and I go beyond just our healthcare systems. I'm looking at too, how our health system is organized, financed, delivered, and then the social and environmental factors, poverty, education, proximity to care, and neighborhood safety. And all of this, but in addition to that, to all these different components, employment, education, all of this makes up one's health. And these all determine health. And so those, and so the the structural aspects, conditions for early childhood development, education, employment, income, job security, food security, all of this makes up one's health. Makes up one's health. And so, and I'm trying to say housing, I'm getting ahead of myself. Housing, social exclusion, and stigma. Folks are isolated. So when we're thinking about this time of safer at home, people being isolated, these all impact one's health. And so and so when we're thinking about equity and health, we have to look at an individual from their life course model and really think about all of these incomes, their early childhood, adolescence, adulthood, all contribute to one's health. I've break down these factors, which we all talked about. So these social determinants of health, participation, social support, leadership, political influences, all of these social factors, one's environment, housing, water, safety, all of that leads to, and in coupling that with health factors, the behaviors, mental health, and then access, it all contributes to population outcomes. And that's what, in public health, that's what we're about. The quality of life, morbidity, looking at sickness, mortality, looking at death, and overall life expectancy. So these are the factors when we think about one's health, that we can't just put everything in the bucket of health behaviors. It's not, and what folks are doing, we have to consider all of these factors. And so I know I'm stressing and harping in on this, but it's very important, because I think oftentimes we're not looking at these factors. And so community trauma, and I'm pretty sure a lot of you have probably heard about this, the expanded ACEs, the adverse childhood experiences, has really, and has really expanded to look at the impact of chronic adversity across a community from factors related to structural violence. And the term structural violence, this is actually came out of Johann Gottling in 1969. It refers to a form of violence wherein some social structure or social institution may harm people by preventing them from meeting their basic needs. So when we're looking at inequitable economic opportunities for folks, looking at jobs, there's the disinvestment and unemployment, where, when we're talking about gentrification and homelessness and all of these impacts of one environment. Deteriorated physical buildings. There's some studies around when you have communities with empty buildings and vacant buildings and structures, how that causes harms to one. So crumbling buildings, dangerous public spaces, inequitable policing. I mean, this is really what has sparked the civil unrest that's going on, within our country right now, where they're over policing, brutality, all of this, and then the vicarious trauma of folks having to live within. So as looking at communities and seeing different folks or Black lives that are being killed at the hands of police, and that constant trauma, and what does that place in that fear that is built up on folks, that is causes trauma. And inequitable access to quality education, because education, we hear about bias, the prison, by third grade, researchers told us the prison to pipe, the elementary school prison pipeline, where young folks are being pushed into prison and pipelined into prison. And by third grade, they're especially our young Black boys are on a different track than other students due to the bias and the fear of the teacher. So we're seeing, and all of this research is coming out and coming about, the transportation and lack thereof and recreation. And so this is what we know about the community. And so when we're thinking about what's going on in these disparities, we're looking at, like within the Black community, 27% live below the poverty level compared to 10.8% of the non-Hispanic whites, looking at rates of drug use within the population. And so this data really needs to inform our practice. When we're thinking about our interventions, what type of work, we need to be looking at the data for all the different populations. I'm not going to read through these slides because if I'm doing work in Delaware, what are the trends in the Delaware data? What is the data telling us? Who's getting service? Who's not engaged? Where are our gaps? When we're talking about advancing equity, our data and how we're delivering our service and who's at the table and who's making the decision and where are funds being allocated is very important. And so we, in each of our communities, this is more of what we're seeing on a national trend, but we should have these same data sets in each of our local communities and municipalities of the different trends that we're seeing within the population. And it supports our efforts to make sure that we are being culturally responsive. And cultural responsiveness begins with us being aware of, well, what are some of the trends? Who's not accessing services, which I'm going to go into in just a moment. Our LGBTQ population. We're seeing stigma and different aspects when it comes to behavior, health, and wellness, and ensuring that we can deliver our services to certain populations as well as important. Rural, when we think about health and wellness, the work that goes on within rural populations, are there access to services, especially like the first bullet, the rate of methamphetamine use by young rural adults, ages 18 to 25, was 0.6% for large metro areas, 0.9% for small metro areas, and 1.4% for non-metro areas in our rural populations. So, and so when we think about our rural folks that we're working with, factors contributing to substance abuse in rural America include low educational, poverty, unemployment, high-risk behaviors, and isolation. So what we're seeing is this trend of the same themes. That's why I'm harping. I'm being intentional. This low educational, poverty, unemployment. I mean, that's almost been on every single slide. This theme that's occurring. So when we think about barriers to care, it's a lack of awareness about available service. There's stigma, and this is going on with a lot of the groups that I just spoke about. There's a distrust of health and wellness system due to historical aspects, and then lack of providers from diverse racial and ethnic backgrounds. I think this is very important. I've dealt and contended this within my own family, where I live in Denver, Colorado, and there is an underrepresentation of Black therapists. And my daughter was looking for a therapist, and she ended up teletherapy with someone that was in another state, because she felt like it was important for her. And I agree that there was someone who identified with her culturally and had that cultural makeup. So when individuals are making this request, because I wouldn't say that any of you all would do this, but it's not unreasonable for us to gravitate to what's familiar. And, and so when we're in these spaces, and when you have groups and individuals who may be, underrepresented in your populations, and they're making these requests, we should try our best to, as organizations, to ensure that we are employing folks that come from the community, that have that background, that has that lens. Because if our whole intent in the work that we're doing is positive health outcomes, to allowing folks to reach their goals, then we would make these accommodations. We won't think that it's an overburden, or it's really not necessary. And, and when we say things like it's really not necessary to have that, you're speaking from your point of privilege, especially if you don't come from that underserved population. There's a lack of culturally and linguistically competent providers. You know, I hear a lot about SAMHSA and those different things. If we're receiving federal funds, by law, we are supposed to adhere to the cultural and linguistic needs of the individuals we serve. It's not an option. Unfortunately, there's no fiscal mandate to these mandates, but we are required by law to address that. Civil Rights Act, it requires all organizations. So if you are a state, you know, sometimes I know state agencies will kick down dollars to locals and community-based organizations. If that money is funneled down to you, you are required to address the linguistic needs of the individuals that you're serving. And then I talked about the economic, and then many LGBTQ people have reported experiencing stigma and discrimination when accessing health services. And so really, when we're talking about equity, equity means all. And I know I'm getting ahead of my slides. And that means no matter one's identity, sexual orientation, racial, ethnic background, geographic region, economic status, they are, it is our responsibility to provide them care. So I've kind of been gloom and doom. I want to transition to hope, because hope is the advancement of health equity. And health equity is assurance of the conditions for optimal health for all people. That's everybody. And achieving health equity requires valuing all individuals and populations equally, and recognizing and rectifying historical injustices. What's going on now across our nation is really, I feel like, built on us trying to skip over rectifying historical injustices. We have to acknowledge it and do our best to rectify. We can't just jump and just say we value all individuals and then skip over this aspects. And then it's providing resources according to need. Now, providing resources according to need is the whole equity battle. And I'm going to talk about this in the next slide. Health disparities will be eliminated when health equity is achieved. So here's the slide. I love this. This is from Robert Wood Johnson Foundation. There you can see the slide. Equality. So I'm all about terms. Equality. Equality is giving everyone the same. So as you can see in this picture, everyone has a bike. But do you notice that everyone has a bike, but is it, and if our intent of giving everyone a bike is so that they have mobility and that they're able to move, well, as you can see, it's not working for everyone. This bike is not helping the person in the wheelchair. This bike doesn't seem healthy for this individual, that it's not the right size. This bike seems to be working, and then this bike does not help for a chair. So equality says we give everyone the same. Equity says, well, wait a minute. If our goal, and I'm using words intentionally, if our intent is to ensure that everyone has mobility, is able to move, and has some sort of transportation in regards to a bike, then we would give the bike that's needed. Now, what's interesting with this picture is I'm sure this bike doesn't cost the same as this bike. And so we might have had to pay more money for this bike, but it ensured mobility. See, this is where the equity conversation gets real. Well, what do you mean we can't just give everyone $100 for a bike? What do you mean this person's bike costs $500? This bike costs $100. This bike costs, 200. This bike costs $100, and this bike costs $50. The point is if we're basing the resources on the need to fill the gaps, to ensure everyone has the opportunity to be accessible. So if we don't understand what provides for equity to begin with, we can't provide health. And I love this quote. And I like to even take it to a whole nother level. I think we know what's needed to provide equity is like, are we willing to do the work that it takes to advance equity? And I like to make this, and this goes back to my comment right at the very beginning of my talk, is making the transition from theory to practice. We can have these great equity talks, but if we're not doing the work to really inform our practice, it just goes by the wayside. And the hundreds of years, the first health disparities report was written by W.E.B. Du Bois in the Philadelphia Negro over 100 years ago. And his outcomes for the health of the Black community are the same now. So the disparities that we're seeing are not new, and things are repeating. So history is ultimately repeating itself because we haven't rectified history. So too often, prevention providers use the language of social determinants of health and the need to reduce disparities, but do not intentionally transform in ways that allow for non-traditional actions required to address social injustice as a risk to the public's health. The major challenge is to move from theoretical knowledge about the relationship of social injustice to increase health risk and poorer health outcomes into broad, sustainable changes in agencies, policies, and practice. We need to dismantle our structures and rebuild to ensure that equity is the way that we are doing our work. We can no longer have these great equity statements and we're about all people and oh, it's just so hard to recruit therapists of color. It's so hard to recruit folks of color. We need to move beyond that and really intentionally change our practice and do the work to change our systems. And so as I'm getting towards the end of my talk, we're going to specifically look at these strategies for advancing equity. And this is what I call that call to action. Equity needs to be a value of your organization. So when we say equity, what do we mean? And a social right. I'm so great that you all are here because this also means we need workforce development and education. We need to support one another in doing this work. And that's why I said we're creating a learning community, because folks are at different levels within their organization, but we're all on this equity journey. It's going to take years to dismantle these systems that weren't designed intentionally for people of color and for certain other disadvantaged populations. In order to do this work and advance equity, we also need to make sure that we use an interagency multidisciplinary approach. So that means that all the prevention folks need to talk to public health folks, need to talk to the labor folks, need to talk to the educators, because in order for us to think collectively, it's the same population. As a caseworker, it was the same because I was, as I stated, I was a caseworker for Denver Human Services, worked in the community, and then I transitioned and became the health disparities specialist for the state of Colorado. I was like, wait a minute, these disparate populations in public health are the same populations that are overrepresented in our child welfare system. So when we see there's common themes of overrepresentations of certain groups of color. We need to partner and work with communities really to get the policy changes and moving forward, really build this up. So that means we got to give people information they need to act collectively in improving their own health. And that was one of my jobs. When you share information with community members, I understand I have my degrees and all this other stuff, but I share information and work in conjunction with community to say, okay, this is the health issue that we're seeing. How can we work on this together? It is not all, I have all those evidence-based models and those evidence-based practice, and I'm not, hear me say, I'm not minimize evidence-based practice, but some of our evidence-based practice does not incorporate that cultural aspect that's being culturally responsive and culturally inclusive. It's things like, well, if you want to get to the community, you got to work in the Black church. Not everyone goes to church in the Black community. And it's not your typical Christian church. What about Black folks that go to synagogue? All these. So there's a vast diversity. So we can't have this one shoe size fits all approach to our intervention. That's what, and if we collaborate with community, like I said, I started in Colorado, the Colorado Black Health Collaborative. We came together and strategically began planning about equity. This started, and it's our own nonprofit organization. We just had we're about to have our 11-year anniversary, and it began by mobilizing, and we think collectively to the diverse needs of our community. Protect people from health problems and health hazards, give people information they need to act collectively, build alliances and coalitions, public policy development and analysis, advocacy, monitor health status, that's the data. Your data should drive your work. Track the conditions that influence health and wellness issues facing the community. It's critical. And one of the things that I want you to think about, examine your practice through an equity lens. And, and that's very important is, and so when we're thinking about doing our work through an equity lens, it's to be deliberate, to be deliberately inclusive as an organization makes decisions. And so we're going to be deliberate. So central questions about implementing the program, policy, or process. What changes did you see in the community? Target population. How did the changes differ from what was expected to happen? How are communities benefiting? And how our community benefit? And with that, there's a caveat. Did you ask the community if they benefited? Are you listening to the communities? And what communities are not able to benefit? And it's just not that hard to reach community, because I've had that. In doing community work, I heard a funder say, well, Cerise, we're not going to fund that community. It's too hard. Well, and I'm like, well, why? So when we're collecting our data, because a lot of this data and information we have to provide to our funders, but we need to begin really dissecting and asking these why. How are results being evaluated? And then have you communicated results back to all impacted? And so that's very important. And so really looking at, did you check back? And then central questions to help design new programs. So if we're going to run out and start a new program, and as you can see, and you see the slide says we got to do the work. And doing the work, it's very important that you're thinking of beforehand. So we're going to do a new program, renew an intervention. Who determines what the decision-making environments look like? Think of physical space, but also meeting structure, frequency. Have all decision makers taken a few of the project implicit tests individually? How will affected communities be involved in defining outcomes and success? It's nothing worse, to parachute into a community because you have this funding and you've come up with your own intervention of what's best and have not asked the community. That's such a disservice to the individuals we serve. Which community should be given priority? And then why is this community a priority? Will a mechanism exist for affected communities to hold decision makers accountable? If I'm creating a program, I'm a decision maker, I already have in place mechanisms to hold me accountable. So for me, I have a whole equity, diversity, and inclusion center. And before we even designed this center, I created a board that oversees all aspects and holds me accountable to our deliverables. So right up front, I did that up front. It wasn't an afterthought. I need to make sure that because when we're doing our work in an equity lens, we all have blind spots. Sometimes our vision can be out of place. And so accountability ensures that we are being authentic to the process and moving forward. And then with the program policy or process benefit from further study or a health impact assessment. So before you implement, are you able to ask all these questions? And if not, maybe you need to take a step and pause and answer some of these questions beforehand. And so this source, and I have a list of sources, checking assumptions to advance health equity, is from our Office of Health Equity. On their page, I would encourage you, it's called Sweet Tools for Health Equity. Check it out. There's no reason to reinvent the wheel. There are plenty of resources of how to really place this work in the practice. So I want to encourage you to be ready to do the work. And then just final thoughts, health equity exists when all people have the resources they need to maintain their health. And what we have to do, instead of hoping that equity will be the result of our work, we must make it the core design principle of our initiative. So that's going back into that health equity lens. And we must be intentional about the advancement of health equity. It just doesn't happen because we've put it on our brochure, or, I'll even take it a step further. We've added it to our strategic plan, but there's no mechanisms for accountability. So if you have an equity strategic plan, first of all, health equity or equity should be infused in all aspects of your plan, but there's mechanisms for holding people accountable. There's timelines for doing the work and moving forward. So here's a list of resources. I would encourage you, if you're thinking of educating and continuing the education, we all need to continue this education, this exploration. Here's a list of resources. A lot of them I shared within my slides. I would encourage you to build them up, and not only build them up, share it with your colleagues. Share this information and ensure, because everyone, I'm going to go back, has to do the work in order to advance equity. Thank you. So Carlton, I'm going to hand it back over to you.
Presentation, a lot of positive comments that came through. I am thrilled whenever I have the opportunity to continue to learn. And I'm thrilled by those that have the capacity to further my learning. So I am grateful to you for an extraordinary presentation. Thank you so very, very much. We've been encouraging folks to put their questions in the chat. Folks, we provided a little bit of time so that we might be able to engage in a conversation with you so that we can hear some of the questions. As you are doing some of that, Dr. Hunt, I wanted to start off the Q&A a little bit and ask you, you mentioned in your presentation the real importance for thinking about and speaking to both the linguistic and the cultural needs. In fact, you shared that for many of us who are receiving either federal funds or funds that are passed through our state that happen to have an origin as federal funds, that we are even required by law to do so. Could you speak more about how we as prevention providers ought to think about being linguistically and culturally appropriate and to meet the requirements that you were kind of speaking to?
Okay, so of course, I think that's a great question. Now this is hard work, and I'm not going to sit here and say that it's easy, because we're talking about our under-resourced programs as well too. But the point about this is, one way, what we want to do is to be proactive. We want to get ahead. I don't want someone who we're saying, because most of our doors are open to everyone. We've done our community outreach, and the worst message that we can send a community member, if they come in, they had the courage to come through the doors to receive care. So I made that first steps. And then you're saying it's welcome to all, because we've made these statements, and then they are not able to get their linguistic needs met. It's discouraging. So one of the things that I encourage all organizations to do a linguistic assessment. You should know before, what are the primary linguistic needs of our community, especially if you're in an environment that has a huge immigrant, refugee population, or your community has taken on a lot of different populations for whatever reason. You need to be aware and have that. Then another aspect, and if you can't, because this is hard, what I've seen a lot of my local health agencies and providers do within my own community is to have a language line. Yeah. And I know, and then with a language line, you can pay, I believe you can pay as needed. But that way, at least you have a language line. And what we've done with language lines is, after we do our assessment, we have a list of all the linguistic needs of individuals. And if the individual comes to our front door, they can point to their language, and then we immediately connect them on the language line. I'm not a strong advocate for language lines, but that's better than nothing. And at least you're able to meet that person where they are. And then if you have a list, maybe as if I'm providing behavioral health services, of folks you can contract with based on the linguistic needs that you can even bring on as a consultant. So just thinking strategically is what needs to be in place.
Thank you so much for that. Delaware is a small state, but it is a very diverse state, believe it or not. And there are a number of cultural and linguistic needs that I know need to be spoken to and thought of as we are implementing these services. Dave, have you been able to identify additional questions that may have come in for Dr. Hunt?
Yes, we've got a couple questions. First would be, one piece of this work that is a struggle is bolstering our behavioral health and therapeutic workforce. Do you have ideas about how we can grow our provider pool and/or provider competencies around cultural humility and awareness?
Okay, so there was a couple, I think, with that. One way to bolster, and I think is the continual training and education for your current staff around cultural humility, and having a series of training and education that's required, that's no longer optional. In addition to that, also engaging your team members may, to take it to that equity level. I'm evaluated, my annual performance evaluation, my boss, the dean, is looking and saying, okay, how have you advanced equity? So so I've worked with organizations that have training plans for their teams, and then it becomes part of their annual performance evaluation. So the whole optional aspects around humility, and we also need to move beyond. There's an assumption because I'm in this trauma field, or I am doing this, I'm in the social services field and in this arena of helping. Sometimes there's an assumption that I treat everyone fairly and I do not have bias, and we have to really move past that because that's not true. So our good intentions can have harmful impact. So that's one. And then another aspect of, and I believe that this was included in this question as well too, and I'm going to answer it anyway, even if it wasn't, because it is a good point. When we're talking about bolstering our workforce, creating a pipeline within your organization. So partnering with your schools that have counseling programs, whether it's social work, human services, partnering with those schools and having internships for students is one way, but specifically providing scholarships and opportunity for your underrepresented group. So if that's students of color, you earmark maybe like some sort of scholarship or something that you all are giving, or an internship opportunity with the intent that you would bring this person on to hire them. So you're creating a pipeline of bringing in diverse workforce. Also growing your own within the organization. Are there folks on your team that you can invest and see that they get promoted? Because at leadership, we'll see that oftentimes there's not people of color in these leadership positions. So then I challenge and push back, well, what opportunities are or leaders doing to bring that voice to the table, ensure, and then compensate? When you have individuals that are doing this equity work, they should be compensated. So if you have team members, because folks like me, I'm very passionate about this work, but it's an add-on to their job. It's an add-on to their responsibilities. If we're about equity, we will pay for equity. Equity, it seems like equity work and community engagement, doing work within community and bringing community members to the table, those are the only two arenas where folks are expected to work for free and as an add-on. And that becomes, then you start getting your team members dealing with racial battle fatigue and all the other different, because now I got to educate my colleagues. I'm telling you, every day I have someone who asks me to do something within my organization. So I'm speaking to this real talk, real time. Ever since of what's occurred, I'm getting multiple requests from Northeast, South, and West and a lot of it is donate your time. We have to, that's a disservice, because if we're saying we're about humility, equity, we have a funding line item budget to support everyone's development and to compensate folks to bring in and to train the workforce.
That's remarkable. We could probably go on for quite some time on this, and I can hear all the amens and the clapping for your last statement. We are coming up on time. And so what I wanted to do is I wanted to ask Dave, are there any additional questions? And for folks who may need to get off because you have other things pressing on your schedule, we totally understand it. We just wanted to give appropriate time for those of you who have questions. We will be able to be responsive to questions that we don't get to do while we're live on this webinar. We will respond to it appropriately afterwards. So if there's one more question, Dave, we can go ahead and handle that.
Yep, we had one more. Would you talk about how an organization might use the Harvard implicit bias tool to begin some of these conversations?
You know, so anyone who's in a leadership role or a supervisor, one of the things that I've done to work is I've had my team members, we all take the implicit bias because everyone can take it on their own. They can do it at the comfort, you know, even give them work time. So, you know, so because it's part of development. And then one of the things that you can do is have a discussion, create these communities where we're learning together. We call these like peer learning networks where folks and teams are coming together to learn, to have some discussions. So then everyone agrees to doing the implicit bias, and then we have a discussion. Now, the only way that this will work is if you create norms of how you're going to function as a team. If there's any tension between teams, it will not work as well. But the whole notion is it gets folks talking about it. Now, the one thing that I can say with the Harvard implicit bias survey, as people engage, you can't force anyone to participate. And leaders, if you're the leader, supervisor, you model it. So the first person to always share what you learned about yourself from the implicit bias is that leader. You're modeling it. You're showing how we can do this as a team. And this encourages folks to trust the process, but then you create the space for folks to talk about it. And if folks don't feel comfortable talking about it in a big group setting, which could be legit, especially if you haven't created that space of trust and created those norms. And trust does not mean that folks will not get hurt in the space. Trust means that if there is hurt, we have a method to rectify. So, you know, because I have people, you can't create safe spaces. And you're right, because safe doesn't mean I'm not going to get hurt. Safe doesn't mean that people won't get hurt in that. But what you're trying to engage is folks to really trust the process and build that. So that would be a good way. And then if folks do not want to engage, then you can do something one-on-one with individuals. And then after you do the implicit bias, there should be some training around implicit bias. You know, you might want to do the training first, then folks do the Harvard, and then there's some reading about bias as it relates to prevention work as well. So it enforces that learning.
Well, Dr. Hunt, I'm sure that there are a number of questions that will be coming in for you. I want to just say thank you so very, very much for an exemplary presentation today and for bringing your passion to the topic as you always have done. So thank you so much for informing our work, informing our efforts. I want to share with everyone that in a couple of days, we will be providing an email to everyone that registered for this webinar. And included in that email will be a couple of things. One will be a link that will have access to this recording. So if you want to kind of revisit what Dr. Hunt provided for us, you will be able to do so gladly. But also there will be a link that will take you to an evaluation, which is incredibly important for us. And so we would ask that you respond to that immediately. You should look for this probably on Monday is when we will be getting this all out to you. So please look for that in your emails. I want to share kind of what's coming up next in our conversation. So within this community engagement series that we are doing through the SPIF PFS RX funds and resources, we will be providing a wonderful conversation around those of you who are interested in the prevention specialist certification process and looking at how we might be able to build the capacity of that. And a great friend of ours will be providing a good bit of that conversation. You will enjoy her as well, Ms. Nicole Augustine. And so that will take place on August 12th at 1 to 2 o'clock. We look forward to you participating in that. With that, I simply want to end by sharing with you all that these needs that Dr. Hunt spoke to us about, all the great work that you all are doing, Ms. Lawler and the extraordinary efforts that she's doing, trying to match the behavioral health systems sources for equity and trauma-informed approaches to the academic systems there in the state are so incredibly important, because we are in a very crucial moment in time. And as Dr. King reminds us, there is an urgency to the work that you all are doing. It is our esteemed pleasure and privilege to be associated with you all in the work that you're doing. We are hopeful that this was informative as well as elevating your efforts. We look forward to any communication, any conversation that you might have for us. Before I end, I will turn it back to our sponsor and host. Abby, is there anything that you would want to offer in a closing statement?
Carlton, putting me on the spot. No, I just want to thank everybody for attending. This was a fabulous presentation, Dr. Hunt. Thank you so much for all of these insights and practical tools and resources and discussion on these really important issues that we all need to be digging into more. So I'm looking forward to, we haven't planned parts 2 through 4, but they're coming. So thank you. And thanks to everybody for attending today. It's great to have you all here.
Thank you all. Dave, thank you so much for your help and your support. Everyone, thank you all so very much. Look for that email on Monday, and everyone have a fantastic weekend. Take care.
Thanks, everyone. Oh my gosh, that was amazing.